Hello, I'm Dr. Sreenivasarao, Surisetty, Associate Professor, Department of Anesthesia, SV Medical College, Tirupati. Today, I want to share some views about the neuropathic pain. So, name itself, neuropathic pain means neuro, this nerve, pathic means pathology. So, some pathology in the nerves. Usually, what the nerves they will do, they will carry the sensations from the periphery to the central nervous system. So, if any pathology occurs in the nervous system, the pain will alter. That is not a normal pain. That is called a neuropathic pain. Let's come to the definition of the neuropathic pain. The IASP defined the neuropathic pain as a pain initiated or caused by a primary lesion or dysfunction of the nervous system in 1994. After that, it was modified in 2008. Pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. So in 2000, since 2011, we are following pain caused by a lesion or a disease of the somatosensory system. So here, what they will remove the word dysfunction. The word dysfunction is now absent from the definition because many chronic pain conditions they are related to the CNS dysfunction without evidence of a nerve lesion or a tissue injury. For example, in conditions like fibromyalgia, we can't find any nerve lesion, and CRPS, complex regional pain syndrome, and irritable bowel syndrome. These are all the conditions where you can't find the nerve lesion. That's why the term nociplastic pain, that is a third type of pain. Now they are calling me. So nociceptive pain, neuropathic pain. Now the third pain is a nociplastic pain. Nerve with lesions, we can sometimes tell it is a recent term. So one different meaning of a neuropathic pain. So nerve without nerve lesion, the patient causes neuropathic pain. That is called a nociplastic pain. So come to the history. Regis and Hali Abbas and Avicenna and Giorgiani in 10th through 11th centuries, they described different scenarios. For Regis described the property of nerve-originated pain, and Hali Abbas described the quality of the neuropathic pain, that is numbness, stingless, need-like pain, and Avicenna classified its causes into the brain, the reasons for the brain, spinal cord, and peripheral nerve pain. And Giorgiani introduced a concept of a traumatic pain and reported that nerve injury was a more painful than other tissue injuries because connections between the nerves and the brain. He also considered as a sciatica as a neuropathic pain. After that, 17th century, the John Fothergill, and 18th century, the Silas Weir Mitchell, and 19th century's French neurologist, and 1911 British neurologist Henry Hart, they added different things to the neuropathic pain. Mostly they are related with the pathophysiology. So pathophysiology is the main thing that we can treat the patient according to the pathophysiology. So now the recent guidelines, the recent studies are they are going on microglial proliferation in at the nerve site. That may be the reason for the neuropathic pain. Like that, since 10th century to the 23rd or 20th century, they are doing different researches in neuropathic pain. Still, we have some ambiguity in the pathogenesis and the treatment of the neuropathic pain. In 2017, the IASP classified neuropathic pain into the peripheral neuropathic pain and central neuropathic pain. So peripheral neuropathic pain usually caused by the single nerve or a group of nerves that causes the pain in the periphery areas. This pain usually not included with the spinal cord or brain directly. That's why it's called a peripheral neuropathic pain. Another pain is called a central neuropathic pain. Central neuropathic pain means so usually the spinal cord and brain will affect here. Central neuropathic pain. Usually the neuropathic pain is spinal cord injury is the most common cause, and stroke, central post-stroke pain, and some demyelinating disorder like multiple sclerosis also that will cause the neuropathic pain. So broadly this neuropathic pain will be divided into the central and periphery according to the site and symptoms that are evoking. So different causes of neuropathic pain, you can see the exposure to the drugs or alcohol, alcoholic neuropathy, toxins, and traumatic nerve injuries or compressions, especially sciaticas like conditions, viral infection like herpes zoster and vascular related neurodegenerative disorders, and nutritional deficiency, usually the B12 deficiency, and cancer related treatment and diseases, and metabolic disturbance like diabetes mellitus and surgical procedures. These are all the different etiological reasons the patient will suffer with a neuropathic pain. So let's come to the incidents. So usually the peripheral neuropathic pain, painful diabetic neuropathy is the most common cause. That is a 26% of the peripheral neuropathy are due to the painful diabetic neuropathy. If you take the same thing into the central neuropathic pain, 67% of the patient there is a spinal cord injury and 28% due to the demyelinating disorders like multiple sclerosis and other things are stroke in 80%. Okay, so this is a pain pathway. So whenever the tissue injury occurs, the inflammation occurs in tissue injury. These are all inflammatory mediators, substance free, prostaglandin, serotonin, acetylcholine. They will release at the injury site area. They will stimulate the nociceptors. Nociceptors in turn, they will carry the pain pathway from the peripheral nerve to the signal transduction and conduction pathway to the dorsal root ganglion. From the dorsal root ganglion, they will form the first generation nucleus here. From the dorsal root ganglion, they will pass the opposite side of spinal cord, and they will go to the ascending spinothalamic tract, and they will give the secondary secondary nucleus at brain stem, and they will end in the thalamus. The third order neuron when the third order neuron nucleus end in thalamus, from there to the cortex. This is ascending pathway. Pain will transmits at the same time from the cerebrum to the brain stem. That is called descending inhibitory pathways. Here synapses will occur ascending and descending. So descending pathways, they will release the descending inhibitor mediates like norepinephrine, glycine, and GABA. They inhibit the transmission of ascending. They inhibit the ascending transmission of pain impulse, so that pain sensation they will not go enter into the thalamus and cortex at the brainstem level only. They will inhibit the pain impulses. So that's why descending inhibitory pathway is more important in treating the pain. So at the peripheral level, what happens? The normal conditions, the activation occurs due to the inflammatory mediators, and the impulses they will pass through the these gated ion channels, and the action potential they will generate, and the impulses they will go through the voltage gated sodium channels. So after some time, the it will persist, and what happens? The sensitizing stimulus they will occur. They will open the sodium channels. Whenever the sodium channels are opened, more amount of sodium ion they will enter into the peripheral postsynaptic area, and they will alter the stimulus. So they will alter the stimulus. More number of sodium channels, more number of sodium channel action patterns they will generate, and excitability they will cause. If the same thing will be continued over some times, what happens? Increased gene expression due to the increased number of sodium channels will open, and increasing sodium ion they will enter. They will cause the abnormal sensitivity, followed by the C fibers deplete denervation of C fiber. That is that since C fibers length will be decreases at the dorsal root ganglion, A beta fibers they will increase, they occupy the more amount of space, and there is a crosstalk between the C fibers and A beta fibers occurs. So this is called a periphery sensitization. So let's see what happened the sensory central level. Central level also the effectors of changes in the threshold and activation of kinetics of NMDA, AMPA, and changes in the trafficking of AMP receptors into the membrane, and alteration in ion channels to increase the inward currents and reduce outward currents, and reduction in the release of activity of GABA and glycine, that is the inhibitory mediators, all will lead to the increased membrane excitability and synaptic facilitation, and disinhibition leads to the central sensitization, causes the development of increased spontaneous activity, reduction of threshold for action potentials, and enlargement of receptor field areas. These are all the things occur in the central sensation. So we are now one is the peripheral sensation, Second is the central sensitization. So you can see the different molecular changes. So at the peripheral level, ectopic impulses along with the A beta, A delta, C fibers of the neuromas and nerve roots and nerve ends and nerve roots they will occur. It is due to the alteration ion channels. That is the increased function of the sodium ion channels. More number of sodium channels they will open, more number of sodium ions they will enter, they will cause the increased excitability. At the same time, loss of potassium channel to modulate the nerve activity. At the spinal cord level, these ectopic impulses at the dorsal root ganglion. What they level at the molecular level, what are the changes? Increased expression and function of the calcium channels. So more number of calcium channels they will release. So this calcium channel, what they leading to increase in the neurotransmitter release and enhanced excitability of the spinal neurons. More along with that, expanded receptor feeds to the NMDA receptor activation by the calcium channels. And A fiber sprouting is very important. A fiber sprouting occurs from the lamina 1 to the lamina to the dorsal horn. They will cross-linked with the C fibers that result in the allodynia. At the cortical level, ectopic impulse occur at the thalamus. What happened? The altered descending inhibition. Descending inhibition is important pathway that will prevent the pain impulses to go upwards. This descending inhibitory pathway will be altered at the brainstem level, limbic areas that leads to the anxiety and depression, sleep problems. Finally, cortical reorganization occur at the central level. So this really, so this one of the important thing is abnormal impulse generating sites. So what are the abnormal impulse generating sites? Where they will project. So AIGS is defined as they are the unmyelinated sites along the damaged axon. Unmyelinated sites in the damaged axon that will causes the abnormal impulse generating sites. So they are the unmyelinated sites along the damaged axon. What happened to the unmyelinated sites in the damaged axon? The number and kind and excitability of the ion channels, wherever the damage, they are altered. So this change in the ion channel distribution and number and kind, they will cause us the susceptible to non-noxious stimuli such as mechanical and thermal and stimuli. So this high density ion channels may result in a resting membrane potential that is close to the threshold potential. What is the resting membrane potential? The membrane potential that will present at the postsynaptic and at resting conditions. That is called resting membrane potential. Whatever they happen, if any stimulus occurs, the presynaptic neurotransmitter release from the presynaptic end, they will open the ion channels. So increasing the positivity in the postsynaptic membrane, that will lead to the threshold potential at the primary level. So threshold potential is higher than the resting membrane potential. So when the resting membrane potential, when close to the threshold potential, what happens? The firing will be easy, leading to the spontaneous ectopic impulses. So first, if any stimulation, the resting membrane potential has to change. It's usually that is -70 or -90. The -90 will go into the up to the -50. Thus, where we will call this resting membrane potential as a threshold potential due to the ionic changes. So whenever the resting membrane potential will be close to the threshold potential, so easy firing, spontaneous ectopic impulses they will occur. The AAGs they will fire autodromically, orthodromically, resulting in constant noxious stimuli in the central nervous system, cause the neurogenic inflammation in the tissues. For this reason, the AIGS can persist even though the primary injury on the axon is completely healed also, they will present. Where axons are disconnected from the distant targets and inflammation spotting occurs at a cause of neuromas. What is a neuroma? Neuroma may become an anatomical site for generating the nociceptive impulses. Together with the neuromas and AIGS and also ganglion changes in the receptor level, they will cause a pain in a phantom limb pain, especially phantom limb pain is a very painful condition after amputation. So, due to the peripheral and central, till now, we have undergone the peripheral sensitization, centralization. So, in peripheral level, what happens due to the peripheral sensitization? Altered properties like a transaction transmission and integration of incoming messages and amplification, modulation of and the neurotransmitter release and synaptic transmission, and alter the descending inhibition control, and causes potential reorganization at the cortical levels, alter descending inhibitory pathway and peripheral level pathway. So this is very important because for any further management. Okay. So this is the central and both peripheral sensation. Finally, the patient will go into the sleep disturbances and mood changes also along with the some potential reorganization. So final pathophysiology is two things. One is a peripheral sensitization, second is a central sensitization. Peripheral sensitization, membrane and hyperexcitability to the increase in sodium ions. They will cause the ectopic discharges due to the resting membrane potential equal to threshold potential. Transcriptional changes that will occur in the peripheral level. At the central level, the hyperexcitability due to the increase in calcium channels and the loss of inhibitory control and reorganization that leads to the both peripheral central sensitization that finally that leads to the neuropathic pain. So how they will present the neuropathic pain? Some positive signs, some negative signs. Positive signs means paresthesia, that is a crawling and tingling sensation, spontaneous pain, burning, shooting like electrical pains, hyperalgesia, increased sensitivity, allodynia, pain responsible to the non-access stimuli. Allodynia means pain in response to non-access stimuli. And the negative signs, hyperesthesia. Hyperesthesia is due to the loss of the C fibers, leads to the sensory loss and numbness. So finally, summation of the signs and symptoms of the neuropathic pain. So, what are the symptoms? Paresthesia and burning pain and shooting pain the patient will present. What are the signs? Hyperesthesia, hyperalgesia, and allodynia. Hyperesthesia means there is impaired sensitivity to the stimulus. These are two types. One is a tactile hyperesthesia, second is cold hyperesthesia, and hypoalgesia. Hyperesthesia means impaired sensitivity to the stimulus. Hypoalgesia means impaired sensitivity normally painful stimulus. Normally painful stimulus that doesn't cause a pain, that is hypoalgesia. But a normal impaired sensitivity to the stimulus, that is called hyperesthesia. And hyperalgesia means increased pain sensitivity to the normal pain stimuli. So that is the punctured hyperalgesia, static hyperalgesia, heat hyperalgesia, cold hyperalgesia. Finally, the patient will land in the allodynia, means pain due to non-nociceptive stimuli like touch and vibration. Simple touch and vibration that will cause a painful thing. So what different things? Class of feeling, freezing, tingling and hypersensitivity, and sharp and jobbing pain and burning sensation and numbness, followed by the this numbness and loss of sensation cause impaired balance to the thing, and sometimes more burning pain on the feet, and sometimes deformities will also occur, shooting pain and painful conditions, and loss of heat and cold sensitivity, followed by. So if you can divide the site, can find the different symptoms. If the changes occur sensory narrow damage level, unusual sensations, pain from the light touch, numbness, balance problems, and tingling. So if you take the symptoms according to the site of level damage. If sensory nerve damage, unusual sensation they will occur, burning and tingling sensation, and pain from light touch. It's called allodynia, numbness, finally, balance problems. And motor nerve damage, muscle cramps occur, twitching occurs, and reflex abnormalities you can find. And the autonomic changes if involves that excessive sweating and heat intolerance and impotence and getting full quickly and orthostatic hypertension. These are all the things where the neuropathic pain if autonomic system is involved. So these are different things what it affects the human being, that is victim. So fatigability, easy fatigue patient will suffer the easy fatigability, and mood changes is more common, and they cannot mobile, so mobility will be affected. They cannot spend the social life and family life due to the pain. They cannot mingle with the family into the art society, and concentration they will like affected, and their work pattern will be affected. Sometimes they will lose their jobs also, and finally their sleep pattern also altered daytime sleepiness, more time of sleep, by taking some drugs also to decrease the pain. So they will increase the drowsiness. And finally, it causes a different psychomotor changes in the patient who is affected for the neuropathic pain. So how to diagnose? So diagnosis is the history and clinical examination and investigations. So there is a possible diagnosis, probable diagnosis, and a definitive diagnosis. What is a possible diagnosis? We will take with the history. History suggests of a lesion or a disease of central system or a history suggestion of a neuronal distribution, that is a peripheral central. Then we'll come to the possible diagnosis and probable diagnosis. For the history, you have to add the clinical examination. Clinical examination, what already we discussed, that the negative and positive signs, he will, the patient will tell us. And along with the clinical examination, we will go some simple investigations, confirmation tests to diagnose that is a pain is a neuropathic pain. If we add three history and clinical findings and confirmatory test only, then only you can diagnose the neuropathic pain as a definitive neuropathic pain. So diagnosis occurs lot of scales, that is a Rowan-Walchuk scales, Menkel pain questionnaire, and dollar neuropathic pain 4 questionnaire, and pain detect land scale, and neuropathic pain scale, and neuropathic pain inventory scale, neuropathic pain symptom inventory. However, these questionnaires have some limitations. They fail to identify 20% of neuropathic pain depending upon the context, because that is only history taken from the patient only. So mental pain questionnaire has the quality and intensity. This is important thing. Mental pain questionnaire. Another is DN4 questionnaire, usually helpful in the diabetic polyneuropathy. Another is the land scale, the pain questionnaire. And second, next is a land scale. These are all the questionnaires where we will find they will help to diagnose. So for example, land scale sensitivity is 82 to 91%, specificity is 80 to 90%. Okay, total score is 24 land scale, and followed by the neuropathic pain scale and neuropathic pain inventory. All the things they will assess the quality of the pain. So they will come to the conclusion that maybe the neuropathic pain. If you want to assess the quantity of the pain, we have some other scales they will do. That is the pain detect questionnaire, pain disability index, the back depression inventory, and depression anxiety stress test, and hospital anxiety depression scale, and profile of mood of status. And along with that, the psychologist presence is very important. Psychologist himself, he will quantify the pain by using some other scales like pain catastrophizing scale, pain coping inventory, the Tampa scale of kinesophobia, and brief pain inventory. Like that, you can diagnose quality and quantity of the neuropathic pain, followed by the examination. The physical examination of neuropathic pain is straightforward and should include the evaluation of tone, strength, reflexes, and sensation, and along with the vasomotor or pseudomotor. This is autonomic pain system involvement or not. It requires a simple paper clip or pin to test for pinprick sensation, and cotton ball or finger to test the light touch sensation. Reflex hammer cooled with tap water to test the cold, and tuning fork of 120 Hz for vibration, and thermometer to test the vasomotor response. All the examinations will conclude the abnormal sensation. The sensation may be normal or increased or abnormal. We will conclude. Along with the physical examination, sometimes the patient may have undergone some investigations like electroneuromyography, neurostimulation studies, and quantitative sense testing and MRI. Sometimes skin biopsy also needed to diagnose this neuropathic pain. So let's come to the management of neuropathic pain. The management of neuropathic pain involves, it's not a simple thing. It occurs physical, social, psychosocial, uh, all the and things will be involved in the neuropathic pain. That's why management will be multimodal approach. So there is a comprehensive multidisciplinary pain team should be there that will alter this. Some people, they have to alter lifestyle changes. So complementary procedures like yoga and acupuncture and physical therapies, they will help in neuropathic pain, and the psychological things, the relaxation biofeedback, and interventional therapies and pharmacotherapy. So finally, the patient will undergo the pharmacotherapy and intervention, but along with these four should also very important to treat the neuropathic pain. That's why we need a more number of persons to treat the neuropathic pain, starting from the anesthesiologist, orthopedic surgeon, physiotherapist, clinical nurse specialist, psychiatrist, neurosurgeon, clinical psychologist, rehabilitation doctor, neurologist, and rheumatologist. Because till now we don't know the exact pathophysiology. That's why it's very difficult to treat the neuropathic pain. It's a different things will be present in neuropathic pain. That's why we need a different specialist to treat the neuropathic pain completely. So treatment may be without medication, and with medication the intervention. Without medication, usually what are our goals? We have to place the nerve in a better position so that avoid the compression, give the opportunity to our nerve to recover by, and prevent the repeated nerve trauma to the nerve, and re-educate the nerve to be less sensitive, and distract the nerve to decrease the pain. These are all the goals of the without medicine, in the without medicine or surgery treating neuropathic pain. So without surgery, so we have to go, we can explain through the gate control theory without medication. So what happened, the pain fibers and touch or vibration and dull pain fiber, they will go through the, they went into the, they will carry from the periphery, from periphery. So what happens, for example, if 100 pain fibers, they are 100 pain impulses, they are coming to there, 100 dull pain or vibration touch the impulse, they are coming to the air. So what is the brain perceives? That is 100 nociceptive impulses the brain will perceive. So what happens if we increase the impulses of the touch and vibration? So if the impulses they will raise, what happens? More number of this dull pain and touch and vibration impulses, they will passes through this pathway. They will block the nociceptive pains. They will come into perceive by the brain. So they will act as a toll gate. So higher number of this touch and vibration, dull pain impulses, they will automatically block the sharper nociceptive impulses. Like that is like what we are using counter return like Amrutanjana. If apply the Amrutanjana, what happens? Some burning and sensation they will occur. This burning pain, burning impulses, they will pass abundantly. They will block the pain path. That is the main mechanism in the counter return things. So the same mechanism we will use by different techniques like therapy splinting and exercise stretching, topical ointments, especially capsaicin ointments is very painful, and acupuncture and TENS unit and mirror therapy. This is a gate control theory. We can use a non-medication treatment. If the medication, these are all the different drugs used for the different sites where for the different pathophysiological changes. So broadly, this management of neuropathic pain, they are divided into the 6 steps. Number step 1, step 2, step 3, step 4, step 5, step 6. In step 1, we can use after diagnosing the definitive diagnosis, they will go to step 1, they will use the tricyclic antidepressants, SNRIs, gabapentinoids, and topicals, topical capsules. In the step 1, they will try for 4 to 6 weeks. If the step 1 is failed, they will step into the step 2, that will they will try up the 4 to 8 weeks. Along with that, they will add from this step 1 to the tramadol and combination therapies. So if the pain is not subsided, then they will go to the step 3. In third line, along with the tricyclic antidepressant, tramadol, some specialist drugs like, here we can refer the patient to the specialist like a the pain physician or a psychiatrist to take care of the pain. They will use the SSRIs, and some pain physician they will use the interventional pain therapies. Followed by the fourth line, here we will do the neuromodulation. And fifth step, they will add the low dose opioids. And sixth step is the targeted drug delivery. Like that, the pain management of the neuropathic pain, it will divided into 6 steps. So first we have to start with step 1, followed if pain is not subsided, step 2. Then if pain is not subsided, you have to go for step 3, step 4, step 5, step 6. That is stepwise approach is very important to treat the neuropathy. Directly you cannot start with the interventional therapies without trying the drugs. Okay. That is the main motto. So these are the different drugs what we are using the neuropathic pain. For example, tricyclic, amitriptyline, nortriptyline, desmoid, imipramine, and we can see the contraindications. So these tricyclic antidepressants, they should not be used in glaucoma patients and symptomatic prostatism patients also we should not use. Other drugs are gabapentin and pregabalin. Second line 5% lidocaine, venlafaxine, duloxetine. Third line drugs are tramadol, morphine, and fentanyl patch they will use. So these are all the different doses. You can refer any textbook you can find, and we should be always care about the adverse effects of these drugs. For example, the tricyclic they will cause a drowsiness and confusion and dry mouth. You have to tell the patient take the more amount of water. If you come to the anticonvulsant, they will cause a weight gain to the peripheral edema. So we should be very cautious when you are prescribing drugs. Okay, in the mean of adverse effects. So first stage, the tricyclic antidepressants and SNRIs and gabapentinoids and topicals. So these tricyclic antidepressants usually effective the treatment of peripheral neuropathy and post-herpetic neuralgia and neuropathic pain, post-spinal spinal cord injury also, but they will have limited effect on the effect on radiculopathy and HIV and chemotherapy-induced peripheral neuropathy. Okay, so these tricyclic antidepressants most important pain relieving effects likely by via inhibiting the serotonin noradrenaline reuptake. If they inhibit the other inhibitory mediators. So after releasing the into the postsynaptic membrane, after activating the inhibition, they will be immediately taken up by the presynaptic end. That the reuptake, that is the reuptake will be inhibited by this TCAs. They can also block the histamine and adrenal and acetylcholine and sodium channels. Sodium channels are very important. And it is recommended that it will done over a 4 to 8 weeks of period we have to get. And we are very cautious while using the elderly and frail to avoid potential adverse effects such as falls, cardiac dysarthrias, orthostasis, hypertension, dry mouth. Okay, you should be very cautious when you are using these drugs in all conditions. Second is SNRS. SNRS they facilitate the descending remission by blocking the serotonin and renal reuptakes. The same thing TCS like they will block the serotonin reuptake inhibitor. They will be useful in peripheral diabetic neuropathy, peripheral neuropathies, and central neuropathic pain also due to the multiple sclerosis. Next, gabapentinoids. They act by blocking the presynaptic alpha to delta calcium channels by the decrease the calcium ions in the dorsal horns and decreasing inhibitory release. They usually effective on post-herpetic neuralgia and diabetic peripheral neuropathy. Nowadays, these gabapentinoids they become the first choice of drugs in treating the neuropathic pain, followed by the TCS. So lidocaine, what does it? Decrease the ectopic firing of the peripheral nerve by blocking the sodium channels. So it usually is in the post-traumatic neuralgia. Capsaicin is a chemical that will binding the TRPO receptors like A delta and C fibers. It causes the desensitization of the nerve due to the continuous desensitization of nerve, and they will cause a reversible nerve degeneration. They will use in the post-herpetic neuralgia conditions. Capsaicin ointments they will use in a herpetic neuralgia, followed by the tramadol and tapentadol. Tramadol is a weak mu-opioid agonist and inhibitor of serotonin and norepinephrine uptake. Second is the tapentadol. Tapentadol is a strong noradrenaline reuptake inhibitor. These are all the true. So tapentadol is it is a potency between the tramadol and the opioid. Nowadays, after gabapentinoids and TCS, after TCS, they are using the tapentadol to treat the neuropathic pain. Third line treatment, third line treatment that should be taken over by the specific pain physicians or specific specialists that will take care of the pain management. So we should refer to them. So they are all serotonin specific reuptake inhibitors, anticonvulsants, and NMDA agonists. These are all the three drugs we can prescribe by the specialist doctors to treat the neuropathic pain. So intervention also done by the third line statement. Interventional therapies, they will do the, as usually the anesthesiologists, they will do the interventional therapies to treat the neuropathic pain. And pulsed radiofrequency. Pulsed radiofrequency also it's done by the anesthesiologists or pain physicians to treat the neuropathic pain, followed by the adhesional anesthesia. If any adhesions occur in the epidural space, the adhesion, the nerve trapped in the adhesions, they will cause the pain and finally they will do the neuropathic pain. The adhesions, we should break the adhesions by injecting the hyaluronase and a normal or hypertonic saline or steroids to the epidural catheter. This will also done by the pain physician and anesthesiologist. This is the third line. And sympathetic blockade, if the autonomic system is involved, sympathetic system is involved to decrease the pain, sometimes we will take the help of sympathetic blockade to treat the autonomic symptoms of the neuropathic pain. And fourth line treatment, neurostimulation. Neurostimulation means they will introduce a device in the spinal cord that will continuously stimulate the things. So that will block the pain pathways. And fifth line is a low dose opioids. And sixth line is a targeted drug therapy. Target drug therapy means the drug amount of drug that will goes and affect the at the target level where the pain is initiated. These are all the different line of managements of the neuropathic pain. So finally, the neuropathic pain, we have to know the diagnosis of the neuropathic pain, and we have to know the epidemiology of neuropathic pain, and we have to know how the neuropathic pain will affect our quality of life, and how to diagnose, what is the possible diagnosis, what is the probable diagnosis, what is the definitive diagnosis by the taking the history and examination, confirmation by the investigations, and we have to treat the mechanism of the neuropathic pain. So if you treat the mechanism of the neuropathic pain, the pain will be automatically treated. So finally, it's a more topic, especially for postgraduates, because ambiguity is there in the pathophysiology. Ambiguity is there. Till now, we are not telling. So we are using some things to diagnose, some drugs or some methods to treat the neuropathy pain. Still, some conditions like fibromyalgia, CRPS, we are not treating the 100% pain relief. We are not giving the 100% pain relief to the patient. That's why it's very difficult to treat neuropathic pain. That's for example, exam going students or postgraduates, it's a more topic, still more to remember, but there is no option to you all because you have to get a marks in exam or to write an exam. So finally, if any question asked in exams, you have to write the definition of neuropathic pain. What is the different etiologies and different pathophysiologies, and how to diagnose, what are the different scales, and how to manage. So non-medical management and medical management stepwise approach, and what are the recent developments. If you write like this, you will get a good marks in an exam. Thank you.